Good evening, ladies and gentlemen, and welcome to the concluding lecture in our anniversary series. Now, as many of you know, the idea behind these lectures was to ask Wolfson people to reflect on what had happened and changed in their professional fields of interest over the half century that the college has been in existence. And because Wolfson is par excellence an extremely cosmopolitan college, it was very important not only that we had these lectures in a physical place, but that they should be available to our alumni, most of whom, the vast majority of whom, live overseas. So all of these lectures are on the web, and you can get to them from the college website. Now, it's a particular pleasure tonight to welcome our concluding speaker. Professor Sir Leszek Borysiewicz, who is a former and now an honorary fellow of the college, has been the university's 345th Vice-Chancellor since October 2010. But as many of you know in this hall, it's only quite recently that Cambridge decided that really it needed a full-time professional Vice-Chancellor. And since that change was made, 2 of the 4 professionals have been from Wolfson. Now, one doesn't like to brag, but sometimes the temptation is absolutely irresistible. Boris, as he's universally known, has been Chief Executive of the Medical Research Council in his time. From 2001 to 2007, he was Principal of the Faculty of Medicine at Imperial College London, and he was later the Deputy Rector of that great institution. He was born in Wales to Polish parents who settled there after the Second World War. He studied at the Welsh National School of Medicine before taking up clinical and research posts in London. In 1988, he came to Cambridge as a lecturer in medicine, which is when he first became a Fellow of Wolfson. He went on to be Professor of Medicine at the University of Wales for 10 years until 2001. Boris has also been a Governor of the Wellcome Trust, Chairman of the UK Clinical Research Collaboration's Integrated Academic Training Awards panel. You get an award for getting that right. And Chair of the HEFCE Research Assessment Exercise Main Panel A assessment panel, which meant he wielded formidable power over the lives and careers of academics in his field. He was knighted in 2001 for his contribution to medical education and research into developing vaccines, including work towards a vaccine for combating cervical cancer. And looking through his CV, you find that he's held many other offices and posts. For example, he was a founding Fellow of the Academy of Medical Sciences in 1996 and was a member of its council from 1997 until 2002. He was a member of the Medical Research Council from 1995 to 2000, and he was elected a Fellow of the Royal Society in 2008. So, if we wanted a distinguished figure to close our anniversary series, then we really could not have done better than Boris. So please join me in welcoming him to the podium.
Thank you. Well, Jim, thank you very much indeed. That certainly is not deserved at all. Today is a very special day for me to be here on this occasion, but it's doubly special because of an announcement I've been asked to make to say thank you on behalf of all the fellows, students and staff and the president of Wolfson. And that is a very big thank you to the Albarada Trust, who have announced that they have given 1.5 million over a period of 10 years to support our students here in medicine and veterinary sciences. And I think that's just a brilliant, brilliant way of finishing. In fact, in many ways, I can just step down now. So our real thanks to the Albarada Trust and to Kirsten Rousing, who is, of course, one of the founders of that trust. Well, prevention is better than cure, 50 years of public health. But now I'm going to break the rules, Jim. I'm going to talk about the next 50 years, not the past 50 years. And in essence, I'm going to break the talk down into 4 areas. A background, some of which is very personal. 4 stages, as I see it, of public health. The concept of prevention is better than cure. dealing with what are the implications for higher education in relationship to this, and then a very quick conclusion. So in starting thinking about this topic, I'm going to turn to 3 books that I read, some as a medical student and one later, so I didn't read very much as a medical student. But the first of these books was an introduction to social medicine. Now, this book was considered unanimously by our year in Wales as the most tedious book you could possibly hope to read. You can see from the cover just how much it would immediately inspire you to read. But it did do something in its first 3 to 4 chapters. You never got much further than that. And I can leave it no better than in the words of Archie Cochrane, when he said that first of all the straightforward story of the ineffectiveness of medical therapy historically, the best account is given by McKeown and Lowe. It was first published in 1966. It demonstrates that environmental factors alone were important, and until the second quarter of this century, therapy had little effect. And typically of Archie, he then adds, one should therefore 40 years later be delightfully surprised when any treatment at all is effective and always assume that a treatment is ineffective unless there is evidence to the contrary. And to an extent, that became a mantra of a cussed medical student who never would agree with anything that was proposed. I do remember a particular social medicine lecture on clinical trials where they used the tuberculosis as an example of why clinical trials mattered. And I steadfastly put up my hand saying, well, if you knew that the treatment against tuberculosis was effective, why did you kill 7 people in the control group? It's very interesting that they couldn't actually cope with the ethical dimension of that question. So you can see I was not an easy student. The second of these was a privilege that I had as a medical student to spend 3 months at the then MRC Epidemiology Unit in Cardiff. There's a longer story to that in why I was called up to the Dean for not attending lectures for 3 months. But Archie Cochrane was in charge of that particular unit. And at the time, he had just completed his, I think, mind-blowing thesis in 70-odd pages of effectiveness and efficiency. And typically of Archie, he had 2 major statements that he always used to make. All medical care that is effective should be free to all. His emphasis was not the free to all, but the effective. And his second was that it surely is a great criticism of our profession that we have not organised a critical summary by specialty or subspecialty adapted periodically of all randomized clinical trials, i.e. what might prove to be effective. The third book is of particular interest and should be of interest to all of us. And it is the Black Report in 1980 of inequalities in health. Douglas Black, then president of the Royal College of Physicians, studied why particular diseases are very prevalent in those in lower socioeconomic groups, even in a society such as Britain. And this is a set of graphs taken from his report, which actually show how many diseases or even injuries and accidents tend to occur disproportionately to those in poorer parts of our society. The findings were very simple. Health, directly linked to social class. Secondly, ill health increases down the social scale. It had little to do with the NHS or access to the NHS, but was completely linked to social factors, income, unemployment, poor environment, poor housing, and education. Unfortunately, for all of us, he could have written that today, and despite 20 to 30 books subsequently, all doing the usual academic thing of reiterating the problem, nobody has come up with a solution. In 2001, David Leon did, at the London School of Hygiene and Tropical Medicine, did a major study which began to analyze the data by life expectancy as coupled with countries who have validated data on that life expectancy and the level of expenditure by that country on healthcare. Now, there are only 70 countries here because they had to have been validated by the WHO that, in fact, the data was correct. And this is the graph that you actually have. And it's a graph that exemplifies inequalities when you begin to look by society. But the good news here is that actually some of the inequalities are good, and that after a bit you actually expend on health quite dramatically. Those of you who are chemists or biochemists would immediately recognize this as a bikinetic graph. You have two vectors. The first vector on the upslope is relatively straightforward. And the major factors defining that are ultimately optimum growth in life expectancy is frankly limited by discovery and our knowledge base and biology, i.e. you can only live so long. The second vector is a rather more worrying one, and I have deliberately arrowed in red. And that is that because this vector is economically unsustainable, but consumer-driven, politically expedient, and in democracies completely unavoidable. And if you follow that out where you see the United States, that achieved the record figure of 20% of GDP now spent on healthcare in the last years. And if you spend 20% of your GDP on healthcare, just remember what you're not spending it on. The countries of great interest are those in the blue circle. These are the countries in transition. Unfortunately, they will inevitably follow the red arrow. But I do like talking about this graph in America, because one of those dots is Cuba. And Cubans live just as long with 1/4 of the expenditure on healthcare as they do in the United States. Why? What are the elements that allow countries in this area and in lower areas to achieve those levels of life expectancy without the expenditure which is very much to the developed world on the far end? The United Kingdom, you will see, is nicely placed. This is before Gordon Brown's increase. It will have moved marginally to where you would see, I think it's Japan on that slide. So let's now examine that particular graph, and let's begin to see what factors might be in common with the investment that's actually made for healthcare in those countries. Well, the first area is public health. The truth is we get more benefit in life expectancy, particularly in the developing world, from interventions that are public health orientated than we get from all the high-tech medicine you can dream of. The second area, and I'm glad that my wife and Ali are here because you've never heard me present it this way before, is primary care. What actually counts is your first contact with the clinician, the ability to conduct reasonably safe procedures, get an early diagnosis, and to deal with the most important issues that are there. But more importantly, what primary care does is to bring to the patient the opportunity of prevention and education. The third element is where the next 50 years will take us. And this is where personalized medicine is going to come into play. How do we begin to take all that information we have about our biology, individualize it, and empower the individual patient or individual to take decisions about their own healthcare and about their own health? The fourth element is this consumer-led demand. You can see where I've placed it on that graph. That's what dominates that part of the graph. And we are all guilty of this. Why? Because this consumer-led demand is something that we put pressure on our politicians to continually deliver, for very good reasons, that at an individual level, it can make a great difference to the individual patient, even though it's going to make very little difference to overall life expectancy in a country. But now we have to think of a fifth component, and it's the inescapable component. And you can see that if you begin to look at that, it is where does care fit into the healthcare spectrum. I keep talking about healthcare, but in essence, the care component is the bit that's forgotten. And the longer you live, the more that expenditure is going to be, and so much is the drive and demand for that area. So at this point, I'm going to turn to 4 stages of public health. And in the evolution of public health in most countries, the first type of public health is the one that works best of all. This is passive public health. You all enjoy it. You will all go home tonight, and some of you will turn the tap on to pour a glass of water. You have just sampled the most important part of public health that has been delivered, a clean water supply. You will also probably use the lavatory before going to sleep, and again, you will have sampled the benefits of public health. This is passive. You get this whether you want it or not. You don't have a choice. And why was it brought in? Well, this lovely cartoon from Punch, which actually shows Father Thames yielding its children to Britannia. The Great Stink and Bazalgette in London did something quite miraculous. And here we need to just think back. What did the Victorians, how did they view this Great Stink in London? They built temples to public health. Look at them. There is the first one. This is Abbey Mills in the north part of London. It's an absolute temple to public health. Internally, look at that. Look at that. Those of you who are engineers, wonderful compressor pumping engines. This was to pump sewage. The Great Stink was removed because the Houses of Parliament couldn't stand the stink. It was not removed because anybody thought disease mattered. But once they removed it, lo and behold, death rates started falling. And the nice thing about the Victorians, my goodness, they really did like to celebrate. If you want to see this, in Thamesmead, there is a wonderful pumping station that has been done out in all of its Victorian splendour. There's another tour of the sewers of Brighton. Some of you will collect wonderful holiday snaps. I go around snapping sewage stations around. Yeah. But they are a wonderful exemplar of what the Victorians saw as technological advance and linking it to health. So the second stage of public health is active public health. This was the onset of vaccination. It's active because you have to do something about it. And controversy, as was then in the Victorian times, still reigns today. If you believe in the vaccination program, this is how you see it. If you go onto the websites of those who are opposed to vaccination, that is how they see it. And notice the word poison written underneath it. The website portrays vaccination as a policy which that an average American child will receive 52 jabs, and this is flooding their immune system. What they seem to forget is all the antigens they might receive. The first breath a child takes in is far more than 52 antigens that they're exposed to. It is arrant nonsense. But that message is the message that pertains to the population. Good or bad? Active means you're making choices. The moment you're making choices, you have no choice over your tap water. You have real choice over this. You can choose to make an erroneous judgment, but I couldn't possibly say so. The third element is associative public health. And these are my own headings, so I do apologize to others who have studied this in more detail. And this really involves health promotion. So here is health promotion, Victorian style. This is Nicotiana being portrayed as the benefit of nicotine to the working classes, the consolation to the poor, i.e. health promotion of the use of tobacco. Thankfully today we have a rather different message, courtesy of the BHF, which was a really hard-hitting campaign of what happens to your coronary arteries if you actually keep on smoking. I think they're some of the most disgusting advertisements I've ever seen, but they made their point very, very graphically, usually over Christmas periods, after you'd indulged in Christmas pudding and other things as well. But nevertheless, here the message is we have to promote a healthy environment, be it in relationship to vaccination, be it in relationship to stopping smoking, be it in relationship to obesity. But again, you're now seeing that the ability of individuals to engage in this is an overall determinant. And I think we're on the verge of a fourth stage of public health, and that is predictive public health. From that importance of personalized medicine and predictive medicine to you as an individual, where we can draw some risk profile for you in relationship to certain diseases, which might terrify you, but on the other hand, the onus on research in the future is going to be to tell you what you can do and empower you to do something to avoid it. Doesn't mean to say you don't get care if something goes wrong, but it does mean you are empowered. And that's a very different approach to public health for the future. So, in public health, I believe the recognition of underlying drivers of health and disease are mostly non-medical. They've moved from the acute diseases to the chronic diseases par excellence. Passive public health has had a huge impact on those diseases. Vaccination and acute prevention is also now very successful indeed. And health promotion will be having a greater impact as time goes on. The good news is that technology has also advanced and is now allowing public health physicians to be able to close the loop, because we now have techniques to be able to monitor and evaluate the impact of promotional messages very effectively. We have screens to know whether you're smoking. We have screens that can tell you on saliva whether somebody's taking cocaine or not. You can begin to predict whether you have an impact or not. But the interventions, these interventions in the future will continue to need technology, but it's much more to do now with the behavior of communities and individuals as to how far they will take those messages. So what are the new directions that in medicine that can result in an improvement in health? If you're at that bottom end of the pyramid, then frankly investment in passive public health will still make a huge difference. You've got an awful lot of years to catch up, and therefore that should be your investment, not in hospitals, MR scanners or elsewhere that many charities do love to donate to such countries. The second area is to make sure you introduce active vaccination programs to these areas, support kids' vaccinations, get rid of those diseases in many countries at that level. And to start introducing health promotion and personal action. A great example is China. China's economy will not run out of power because of its difficulties with the remedial or elsewhere. It will run out of power because 30% of all deaths in China are going to be related to cigarette smoking, and that clock has already started ticking, and it will happen in the next 10 years. There's a prediction for you. The economy will slow down because it will be losing its leaders due to their absolute predilection for smoking. So this is essential for all countries. Now, primary care, for me, stands as near patient intervention. And we're going to need new technologies to make primary care and to change primary care into the future. Point of care diagnostics. These are going to be absolutely essential, but they have to be low cost and they have to be screening in their mentality. We need to consider effective treatment implementation. This isn't just doing clinical trials and telling you what works well, but linking appropriate and more accurate diagnosis and patient stratification to the appropriate therapies, and making sure that those therapies are then taken. Education, the reinforcement of public health messages. This is smoking, obesity. Okay, but actually you can begin in the future to reinforce those messages day in, day out through the mobile phone, through online learning, making sure an email arrives in the morning, wanted or unwanted, and cannot be removed, to tell you that you have eaten too much for breakfast, or that you haven't walked enough steps, as your Apple phone will tell you already. I have to tell you, there's no evidence that 10,000 steps makes you any healthier or not. It's an arbitrary number plucked out of the air by Apple, but we all look at it. Active prevention. You know, our fall in maternal and childhood mortality and morbidity is no happenstance. It is a very active process that has been pursued, particularly through primary care, to make sure those interventions work, and the delivery of great obstetric care. And then we have active management, which is already happening of chronic diseases in primary care. We need to be able to monitor them more effectively to make sure the treatments are actually appropriate at the time. And there's a huge amount of work to do in this space in order to get the best outcomes and results for expensive treatments that have to be applied. But it's a different mentality that will be needed in primary care, and a different style of education, that your role is as much about health promotion and using technology to continue that message of health promotion to keep you healthy, as well as to look after you when health begins to deteriorate. And lastly, the gatekeeper function. The gatekeeper function is absolutely vital. And for this role, you will need data information about the whole system in an assimilable form transferred to the primary care physician or primary care health worker. That does not exist, because it has to be rapid, it has to be responsive, and frankly, all of this information is going to be critically dependent on data-related technology, which I believe will be key to all of these elements as time goes on. So who is going to be responsible? How are we going to deliver it, and where? And this is where it becomes very difficult. Who? Oh, of course, you'll all say, well, it's the general practitioner, the health nurse in a healthcare centre. Okay, who is it targeted at? Are we now targeting the worried well, who are going to cause, as any general practitioner will tell you, are the bane of the existence of general practice? Will be in there every 5 minutes, blocking up the slots that you've been waiting to get at. But that is the population that will grow. And when we provide even more information, they're going to get even more worried. The patient is often now supported outside of conventional healthcare. Those of you who've had the privilege of working with patients with cancer, if you really talk to them, will know they've studied every conceivable website there is relating to their disease. Wouldn't you? Wouldn't I? Do you have the knowledge to be able to refute some of those arguments, to be able to say 99% of what you've got there is complete garbage? Do you have the confidence to say that? How is this going to happen? Well, a lot of it is unfortunately going to be online, and every conceivable form of public communication. What we're seeing with the online generation, they're more likely to ask their friends as to what is likely to be wrong with them than actually to go to the general practitioner. And the advisors in the business world who are beginning to run opportunities such as 23andMe will be providing their own advice to them based on their results and transmitting it to them, so that by the time you see the health professional who might really know what to do, they've already changed their mindset as to what the issues of causation, treatment, and others expectations they may have of the underlying condition that they might be suffering from or not. That is not easy to deal with as a healthcare professional. And where is this contact going to take place? You would instantly say your local health centre. It'll be everywhere. It'll be on that morning train ride to London on the train from Cambridge Station. So the nature of what primary care really is about is actually about to change during the next period of time. A completely different set of messages, and how we get them out and how do we work effectively in this space is going to require little short of a revolution, just at a time when investment in primary care is probably at its lowest ebb ever. So we then moved on to personalised medicine, because this is where it's going to get really exciting for those of us who are involved in research. But the key trends are that you will now have access to self-diagnosis and healthy living information provided by third parties who you don't know. You have no idea of the quality of the information that you're getting, and yet they will be very convincing because the ones with the least quality have the glossiest websites. How do you know what information you're getting is of any value? Well, if I have a cancer-related problem, I would go to the NCI website, or I'd go to Cancer Research UK. If it was cardiac, I'd go to the BHF website, because you know these organisations are pucker. 99% of people in this country wouldn't even know where to turn to. And believe me, the vegetable cures for HIV were promoted in South Africa for beetroot and elsewhere through very glossy websites telling you don't need these horrible antivirals, just take beetroot and your HIV will go away. Tragically, it didn't. The direct provision of these trends outside of the conventional healthcare setting is a reality in many fields, particularly in the cancer area, and will gradually become more and more evident. And self-help and support groups, when they've made an instant diagnosis, you will get a contact to a health group. If you've got an erroneous diagnosis, they will immediately reinforce that particular disease empowered. So how do you empower individuals to seek that advice because it might be beneficial to them without destabilizing the healthcare system altogether? Well, technologies are going to be part of the answer, and this is where precision medicine is going to come into its own. There's a difference between personalized medicine, which doesn't just rely on diagnostic, and precision medicine, which actually focuses on technologies that are specifically designed to give you better predictive value. The advantage of precision medicine is that it's predictive and can be regulated in relationship to quality, although nobody in the world knows how to regulate it as yet, but at least has that potential. And self-diagnostics. That is all there for you. If you want to know whether you carry the BRCA1 gene, you scrape your cheek, send it off in an envelope, you'll have an answer in 2 days' time. Have you actually thought what the consequences of a BRCA1 mutation are for you, for your family? What are you going to do when you receive that answer? And it's an answer many women would, in this day and age, would want to know because it's highlighted in the media. Who's going to have to pick up the pieces? Well, it won't be the specialists, it'll be the primary care physicians. Are they equipped and trained to be able to do that? And can the whole clinical community, and I don't just mean physicians here, the whole clinical community respond to this? And if you're doing this, the gatekeeper role of entry into the NHS is completely gone. So who controls the expenditure, or do we just escalate healthcare costs out of all recognition? Because once you've got something, believe me, you'll be demanding the best treatment possible and will not accept a rationed care system if you know in advance that you're at risk of a particular condition. That's human behavior. So in essence, for this group of countries in the middle, the point of care diagnostics and screening would be very important, and precision medicine will straddle that whole area of personalised medicine and the area of primary care, probably going even into the public health domain. But the key thing is all of this will require individual action, not clinician action. The power will be moved to the consumer or the patient, depending on the language you like to use, in making those decisions. So now we turn to where consumer-led demand is going to take us. Now this is never ending. There is no end to this. Patient-led demand, the providers want to have better technologies because they want to provide better care for the patient. And a political demand because actually a new shiny machine and gizmo is a lot more interesting than providing 20 extra nurses who actually know how to interpret a BRCA1 result and to support a patient. I.e., the expenditure is on fancy kit very often rather than expertise. And it's extremely important that this continues, but it has to be very carefully evaluated if we want to maximize benefit for disease-specific outcomes. It will always be science and technology-led in this particular domain. even the science and technology of the best capacity to learn. But high tech equals high cost. So I'm afraid cost escalation here is almost inescapable, but carries huge potential individual benefit, but marginal population impact. So you pays your money and you takes your choice. And this is the sector where the private care sector will infiltrate very quickly, because the profit margins here are very high compared to the high volume you have to deal with in relationship to primary care. The question mark is this sustainable? In a way, the answer of high cost and diagnostics and therapy, or provider-led competitiveness, I will argue, is in the long term completely unsustainable. And the reason for this is this, that each of these trends is going to drive up the demand for care. And it's not the healthcare costs themselves that are going to escalate, those the treatment costs, it's the care costs. Because if all of these things are effective, you're going to live longer, and you spend about, I understand it's over 2/3 of the healthcare expenditure is in your last 9 months of life. Whether you're 9 months or 99 years and 9 months, you will still incur all the costs at the back end of your life. And that is unavoidable cost. So frankly, if you want to be a very good citizen who is completely altruistic, might I suggest that you take up smoking at the age of 55, pay the taxes on cigarettes, drop dead at 67, don't spend your pension, and make sure you actually die of a heart attack. Sorry, Peter, but it's at least quick, clean, and doesn't incur costs. Very socially responsible. Care. This is the largest driver that we will face, and the biggest cost pressures. And they're unavoidable if we live in a caring society of any sort. It's driven by demography and dependency. Japan will now only have 2.7 people working for every dependent individual in that country. What that means is it does not have the manpower to go into the care sector to deliver care, and therefore when we laugh at the Japanese tea-making robots, they don't laugh at it at all, because that's what you're going to need if you want a cup of tea in a healthcare home. Or we talk about retirement villages, where in essence you have commune of retired individuals who actually look after and care for each other. This is a big cultural change we're going to be faced with, and cultural change far more difficult than delivery of new technologies. The cost is human, social, and financial. Lack of any technological solutions. God, what an opportunity here if you can solve this one. But it's divorced from overall healthcare cost, but its indirect impact is every time you hear on the news, I think it was last night, Northampton General Hospital saying it can't move 20% of its patients because there are no beds available for care in the community. So demand is almost infinite. Rationing or disproportionate removal of funding from other key governmental responsibilities is the consequence. And if you think this is a problem for developed countries, it is, but it is minor compared to countries like India. Here is the current data from Srinath Reddy for India, from death mortality in India in 2004. Notice where cardiovascular diseases and diabetes is already. This is not a revolution that's about to happen. It's happened. And those countries are going to have that care and care for chronic disease burden when they can least afford it, because they don't even have a healthcare system organized for acute problems. Attributable factors? Well, surprise, surprise. I suspect any physician in this country would write out exactly the same system of high blood pressure, suboptimum blood glucose, low fruit and vegetable intake, tobacco use, high cholesterol. It doesn't read like something you'd expect from a country coming out of development status. That is the reality in 2004 in India. And projected deaths and burden of disease, you will see infectious diseases falling off down the bottom there, but what you will actually see is cardiovascular disease rising, cancers rising, non-communicable diseases. Those are in terms of mortality. Perhaps more worrying is the data of projected burden of disease. because in here now neuropsychiatric disorders begin to dominate. And those of you who have worked and studied India and the developing world know that the provision for neuropsychiatric disorders is virtually non-existent. So let's return to this schematic. There are my arrows all going into care. But I've now removed the back end of the graph and I'm going to do the quadrant thing. If you're in that top quadrant, what you're delivering is high cost, low population impact. The other quadrant is high cost and high population impact. Personalised medicine isn't going to come cheap. Primary care does not come cheap. The real benefits are down here, low cost and high population impact. Well, in many countries we've done all of that, and everything is going to come at a cost. But the most difficult, and you would of course expect me to say low cost, I'm just going to say it's unavoidable. That cost is already being incurred. So what is our politicians' response to this? That's what happens. You grow the care and you grow the consumer-led demand because that is what is politically expedient, and you ignore the various sectors where the greatest potential benefit can be raised. And that is as true for a developing country as it is for a developed country. Play the mind game for a minute. What happens if we convert it this way round? If you're in the commercial sector, now you've got to start thinking, is this a good investment to be actually making the better scanner at, £30 million a throw? Or does precision medicine actually drive this problem into primary care? In which case we've got some serious thinking to do. What does the system look like in the future? Because if we don't deliver it, I'm going to go back to one of the 3 books that I did read. Health inequalities come straight to the forefront and hit you between the eyes. Because you can deliver benefit which might impact on health inequalities, but not if you continue to drive the consumer-led demand at the far end of this message. So back to old Archie. Medical care that is effective should be free for all. I suppose what I've said is, not so sure anymore. I do agree with him. It's a great criticism that we haven't actually been able to assimilate all of the data on effectiveness in delivery. But there's something that's even more important that is often forgotten. Is the title of his book was Effectiveness and Efficiency. And it's the efficiency bit that is always forgotten because we equate him always to clinical trials. But he was equally scathing if we cannot deliver efficiently that which is effective. So what does the Vice-Chancellor do about it all? Scratch his head, go to sleep and forget it because it's all too difficult a problem to solve. Well, I refuse to do that. I think there are some very important things we can do. The first for me is what's becoming a bit of an obsession in the university for me is education. The faculty that's the youngest faculty in this university, one that's often forgotten or talked about as faculty just emerging, is education. If the consumers are not educated enough to be able to seek advice and to get advice, then frankly we failed, because all of this personalised medicine, all of the developments are really going to be completely ineffective. So for me, maybe prevention is better than cure. Those of you who don't believe me, look at the UNESCO report on education for all for developing countries. 2 figures absolutely shocked me. The first of these was maternal mortality. Do you know the biggest way to cut maternal mortality? Educate girls to the age of 14 instead of 10. You don't have to change the healthcare system at all. You will halve maternal mortality. And if you want to halve childhood mortality, don't change the healthcare system. Guess what? Educate girls to the age of 14. In other words, this matters because the person is being empowered to use systems better. Should we be applying public health rather than high-tech principles to the higher education sector? Higher education for all. doesn't sit comfortably with absolute excellence in everything that we do, who should actually be the beneficiaries of higher education, where does that actually stop? Does this only apply to public health, and do I take a view that actually we shouldn't be spreading it? Well, my answer would be very firmly that we should be looking at countries that require improvement in education systems and help those countries to promote higher education so that they can develop their own leaders that are equally cognizant with the issues that they face and take a responsible view of their society. So my view is, unashamedly, that is the international direction this university should be taking, is to work with other countries to support their tertiary education institutions so that in country, every country can develop its own leaders. Because those leaders, call them elite if you like, but those leaders are the ones who are going to be able to help that country best and in the long term to help pursue a healthy agenda for that country. What about the nature of training and education for those who are going to be professionals in the field? What should we be doing about training a cadre of individuals who will not be the high-paid physicians and surgeons and technicians that we have at the present time, but actually who will have to address some of these SNEED-led needs? What does that sector look like? Frankly, how much do we pay them? How much is it going to cost? I don't think anybody's got any answers to that, but it's certainly something we have to grapple with. And I think for a Vice-Chancellor, the most important area is this is a world of opportunity. And a world of opportunity is only there because we can tackle things in an interdisciplinary way. Each and every one of us works in particular departments, or silos, as I would still refer to them as. The real excitement in higher education is happening at the interdisciplinary divides. It's how you bring sociology and microbiology and economics together to develop a better pathology service that can actually work out. Or in the energy field, how do you make sure that a technological solution to clean energy is acceptable to society such that it can be implemented? It's the efficiency message of Archie Cochrane's dual-headed magnet of effectiveness and efficiency. But the real opportunity is in innovation in healthcare. And boy, is this university full of innovators who can make a big difference. You don't often think of Cambridge this way. We're Europe's biggest technology cluster. And we're rapidly becoming Europe's biggest biotechnology cluster. 1,500 high-tech companies, 60,000 jobs, 13 billion pounds to the exchequer. It's huge. And I have 14 companies worth $1 billion, and I wish you'd probably wish you'd invested in those two worth $10 billion or more. These are fantastic outcomes. And this is all in a region with just 1% of the population of the United Kingdom. That's why Cambridge and Cambridgeshire is seen as the goose that's laid the golden egg for the economy. That's why the Chancellor of the Exchequer is so interested in what is going on here. But in healthcare, what an amazing opportunity for us. The huge pharmaceuticals that have actually moved into this domain, to be able to work with academia and industry alongside each other to deliver products that can actually make a difference. Devices that are going to be necessary for that point of care diagnosis, those devices that allow you to monitor your own health. We're in the forefront of developing those. And the care sector, begin to think about it. Just the simple application of GPS in the home. Those of you who had to look after parents or elderly relatives whose memory might be falling, if they live 100 miles away, what do you really want to know? Are they lying at the bottom of the stairs? Have they turned the kettle off? Have they made sure that they're warm? Is the temperature in the house okay? You could do all of that from your Apple phone and control it all. So care is susceptible to technology, it's susceptible to innovation. But coupled with all of that is we will be the leading centre, and why we've been selected to be the leading centre for precision medicine and driving that whole innovation area in precision medicine, because we have all of the technologies based here to develop the new companies that can grow and really impact on this system. But there's also something else the higher education sector has that's invaluable. And it's under that word influence. There are two broad models for where influence pervades in both the consumer private care model and in the social care model. Let's just run through these. In the private consumer model, the usual arrow is the demand comes from the consumer and the purchaser has to deliver it. The purchaser, in his usual way, will immediately knock that on to the provider and say, your responsibility to deliver the needs of the patient or consumer in such a system. The provider is also under pressure from the consumer because at the end of the day, they have to actually acquiesce and want to attract those patients because that's where they will be able to make their margins on healthcare costs. Politician, elected representative, well, if it's truly private, that's a pretty small arrow. It's in light blue. It's nice to have, but doesn't matter too much. Obviously, politicians, because they're elected in democracies, even with private healthcare, will put some pressure on the purchaser to be able to deliver effective care, but that's usually through taxation and other means to force them to do it. It isn't a great state responsibility. The purchaser will want to attract business from the customer, so there will be an arrow of always trying to inundate the consumer or the patient with information in order to choose a particular purchaser or HMO-style provider. The politicians want to get re-elected, so periodically they will tell the consumer what they've actually delivered during their period in office. And the purchaser will have to show the government or the elected representative that they are actually doing something for real benefit. So it's a really interesting model that then begins to develop. Where does influence really sit in such a model? Well, the influence sits at the provider and purchaser. So in such a model, it is about innovation, and you're going to provide that influence through the provision of new discoveries and technologies to the provider, and you can begin to influence the purchaser because you can tell them what is more effective or efficient. That is the way you do work. In the social care model, it's rather different. The patient or consumer does impact on the purchaser. The purchaser hugely impacts on the provider. The demand is from the purchaser to the provider to deliver. And the provider will endlessly inundate the patient and consumer to tell them how good they are. Now, the consumer can only really exert influence through the elected representative. And therefore that arrow becomes really important. And the elected representative, or as usually they will do, merely deflect all of that away from themselves and their responsibility and dump it onto the purchaser. But the purchaser will want to get the patient or consumer to actually feel satisfied so that they can influence the elected representatives. And again, you've got the same arrows that would normally interface in this model. But we can influence that system by providing objective evidence and in such a model in a different way, because we move away from the purchaser and provider to maybe empowering the patient and consumer to seek more action and to influence government to make appropriate funding decisions in relationship to what is effective and to ensure it is efficiently delivered. So there's a lot there. These are my personal views. They are not related to anybody else, and they're not related to university policy. There's the health warning. But what conclusions can one draw? Healthcare is the largest market. It's the largest market for anything on this planet. So don't think the private sector is going to ignore it, no matter how much you may rail against the private sector. The market is 10 billion potential customers, most now in the developing world. Can the developing world turn that to an advantage? It's infinite demand. If I stood here with a bottle of pills and said, this is £10,000, I guarantee you, you will have 3 months of added high-quality life. I'd like you to put up your hand if you would not want to bid for this bottle of pills that would give you 3 months guaranteed of high-quality life. The demand is absolutely infinite because it's a commodity we all want to buy if we possibly could. And therefore, in the political sphere, This is a completely unattainable political driver. Ultimately, if the United spends 50% of its GDP on healthcare costs, it will never satisfy the demand. And cost to the individual is almost immaterial, because an extra day of life for you is worth far more than the government will ever value it at. NICE, what is it? I can't remember. It's about £36,000 a year. That's what 1 year of your life is actually worth to NICE. I think you'd put a higher value on it than that. So technology, for me, is still a key. And it's this that will continue to show whether this university or any institution can continue to occupy a leadership position in healthcare innovation in the future. But it cannot be the overriding consideration if what I've suggested to you as a hypothesis is the way in which the trends are going to have to grow if you're going to be able to deliver health for all in the sort of model that Archie Cochrane originally envisaged. Innovation and entrepreneurship, whether we like it or not, are going to be the drivers. And don't think the drivers for that entrepreneurship are about the benefit to healthcare. Oh, that's a good post hoc evaluation. Much of the entrepreneurship will be driven by a for-profit motive. And thank goodness it is, that's at least an honest motive to be doing it for. And so the for-profit motive is perfectly acceptable if it can deliver good, effectively and efficiently. And we have to live with that. And effectiveness, but increasingly the efficiency with which it can be delivered is important, and that is what will ultimately define healthcare systems in the future. So we will measure effectiveness, but increasingly we will have to develop efficiency if we're to keep the healthcare costs down. And that is a transition that is going to be extremely difficult to make in our country, even though we have a socialized care model. In the United States, ever more difficult to deliver, and in the developing world, a real challenge to do this with the growing demand coming from there. And that interdependencies in the system, as I've tried to show you, between the purchaser, the provider, the elected representatives and the consumer are all important in how this develops. So the question I want to leave you with tonight: are we really prepared to engage with the seemingly insoluble whole systems problem? And that's the challenge I want to pose Cambridge University. You're full of very bright people. This is a much more interesting conundrum to solve, and we need every discipline in this university to help us solve it. Thank you very much.